members that as a committee of the council it is being recorded and streamed live on the council website. Members and guests would have noted we have a full agenda today, so we'll continue using the flagging system, letting people know they've got 2 minutes remaining for their presentations and Q&A. As part of housekeeping, I just want to remind everyone that the fire alarm test will take place during the meeting at 11. And I've received apologies in advance from BJ Harrington, Julie Rogers, and then both Jim Nicholson and Councillor Johnson and Elwina Sorban have apologised for not being here in person, but have joined us virtually. Are there any further apologies? If you just press your button and it goes red.
Oh, there we go. Sorry, Jill Barnes. Jill Burns. I'm here representing her. But unfortunately, she's not well today. So obviously she's off. She's not here, but I'm representing her. I'm Sharon Hall. Thank you.
Thank you.
Steve Porter, can I just express Anthony McKeever's regret for not being able to come today as the Chief Exec of MSC. Alex McCann, who's a new Alliance Director, is here alongside me today. So hopefully we can represent him and report back.
Thank you very much, Stephen. Any other apologies?
Councillor Arnold, we also have Councillor Muldowney, who's provided her apologies this morning.
Thank you. I'd just like to say that now that we've got the chamber pretty much working and we're able to get together, it would be nice if maybe more members could occasionally join us in the room rather than just virtually. I think it makes a bit of a difference for having those chats and feeling like we are giving this health and wellbeing meeting the importance that it deserves. It's one of the top 3 strategies for local authorities and government to feed into, so it would be good if people were here to join us. Before I continue into the formal agenda, I'd like to remind colleagues of the importance of submitting reports in a timely manner and on the correct report template. Late reports and those without a covering report may be deferred if any of the deadlines set are problematic. Please do let us know. And going forward, if you can use the right templates, one of the reasons for doing that is that the council and local authorities have worked out font sizes, font styles, formatting on the page for easy reading for those with sight difficulties and things, so it does help if they are on the correct template. Moving on to the agenda and item 2, minutes and actions arising from the October's board meeting provided at page 5 of the meeting papers. Are members content that the minutes are an accurate record?
Agreed.
We'll now consider the action and decision log. Paper copies have been provided to members and will be circulated electronically to those attending virtually. So hopefully you will be able to see an action log if you still can't see us. There are currently 5 decisions open on the log. The decisions reflect the board agreeing proposals on previous agenda items relating to the health and wellbeing strategy, domains in focus, domain 1, healthier for longer, domain 6, community safety, actions 14, 17 and 19, better care fund, action 20, and annual public health report, action 24. Decisions are recorded on the log and are closed following members' approval at the preceding meeting. Are members content to close the decisions and for them to be closed and recorded as an accurate record on the log? I can see some thumbs up on screen and nods in the room, so I'll accept that that's agreed. There are several actions on the log for which I can update members. Action 13, Kim James to liaise with Stephen Porter to promote the CVS cost of living event in December through health colleagues. Cost of living event details were received. MSC will be promoting this via their website, and it will also be added to the PCN websites. Social media posts will be shared and leaflets distributed. MSC colleagues have confirmed their attendance at the event. Kim's not here. I don't know if she's online. I know Stephen's online. Have you got anything that either of you would like to add?
Not for me, Chair. I think that's fine. We've done all the things you said.
Thank you. Action 15, Michelle Cunningham to consult with partners to investigate the use of OnlyFans for the exploitation of young females and to provide an update to members of the board at the next meeting in December. Is Michelle with us online? Right. The Community Safety Partnership have not had any local issues raised with regard this, and it will be discussed at the CSP exec on the 1st of December 2022 as part of risk monitoring. Well, that meeting will have gone ahead now. Have we got a further update on it? Right, okay, Councillor, I'll ask her. Can we ask her to email members and give us an update from that meeting? And then we can take questions perhaps at the next meeting. Action 16, Michelle Cunningham to provide the board secretariat with details of the champion process. This will then be sent to political members for consideration by the 25th of November. That's been completed. I've been acting as the domestic violence and sexual abuse against women champion. I've joined Michelle on some community events with police safety officers, which I can only thank them because they were doing a fantastic job, and it was really encouraging to see people, men and women, engaging with them at the station, at the train station, I mean, not the police station. Action 18, appendices for Domain 1 and 6 will be supplied to the board at the next meeting. These have been provided on pages 19 and 24 of the meeting papers. Action 21, an updated initial health assessments report is to be presented at the next board and will be taken as an urgent item. That's on the list today, and actually it's our agenda item 7, but we'll take it as our first report because I know, Janet, you need to be able to get off as soon as possible to another meeting. Action 22, the under-doctoring position in Thurrock Host paper is to be added to the board forward planner for future discussion. This has been added to the planner for the February meeting. The presenter of the report will be confirmed by Alexandra McCann and Will Guy. Action 23, Stephen Porter to provide the chair with the latest data from the QOF registers. I understand that that's not managed by SMC, Stephen. I did read your email, thank you. But by the NHSE, and QOF is a national NHSE programme, therefore you don't monitor it, and I've asked Joe in Public Health to take that up for me and to get some more information. Are members content to close the actions?
Agreed.
Yeah, agreed. Nodding heads, thank you. Moving on to agenda item 3, urgent items of business. I've received an urgent item for consideration, the Adult Social Care Discharge Fund. The guidance published by the Department of Health and Social Care on the 18th of November stipulates that the local authorities and ICB funding allocation should be pooled into Local Better Care Fund Section 25 agreements with plans for spend agreed by the local authority and the ICB chief execs and signed off by the Health and Wellbeing Board under National Condition 1 of the Better Care Fund, Condition 1. It's a jointly agreed plan between local health and social care commissioners and signed off by the board. The guidance further stipulates a completed spending template should be submitted 4 weeks after the fund details are published, which is by the 16th of December, confirming planned use of the additional funding and that the use of the funding has been agreed by the ICB and local authority. The timescales for developing and agreeing spending plans are challenging. It's been pretty quick this week, I think, Kerry, for both the ICB and the Council. I'd like to ask Kerry Armstrong to introduce this item. And sorry, I meant to mention, Claire, that Les Billingham has sent his apologies. He's really not very well. He's gone home. 10 minutes has been allocated for the presentation discussions. Thank you.
Thank you, Chair. Again, apologies that members of the board have received this paper last minute, but as is normally the case when we get winter pressures monies, we have very, very little time in which to turn around the spending plans, and that's no different for this year. This year, the fund is known as the Adult Social Care Discharge Fund, and for 22-23, and the deliberate kind of title is because it's very much linked to discharge of people from the acute sector into the community, with the focus being on home first, although we know that for a number of people that isn't the case and they may need some intermediate care options before returning home. So in terms of, I'll just give a quick summary of what's in the paper, and then there may be some questions, and I know that Stephen is on the call as well and has been involved in the process, and is able to answer some of the details should I not be able to. So the request is for the Health and Wellbeing Board to sign off the spending plan, and that's in the details that come down from government. There are two elements to the spending plan. The total is kind of not for Thurrock alone, but the total nationally is 500 million. And you're right, Councillor Arnold, the details came to us late November time, and we have 4 weeks in which to actually kind of turn around and get the plan agreed and submitted. So there are two elements to that. 40% of that 500 million is distributed to local authorities, and our element of that for Thurrock is £545,000. And there are 60% allocated to local authorities via integrated care boards. And again, our element of that is 443,000. And there are two tranches, in the way it's released, there are two tranches, 40% being released to us in December and 60% being released to us in January. The slight difficulty is that it has to be spent over the winter period, so it has to be spent by the end of March, if my understanding is correct, by the end of March 2023. So unfortunately, in terms of the speed of kind of identifying schemes and actually spending, they have to be allocated to things that we know are going to be used and of value during this very short period of time. So there are details in 3.32 of the paper, which is around the ICB element, and I'm quite happy to go through those if you need to, but I think everyone's got the paper, so I don't intend to unless there are any specific questions. And then the local authority element, so that 545,000, is detailed in 3.3.3 of the report. And for both, there are slight underspends because, again, it's very, very difficult to understand or to identify exactly at this moment what all the spend will be, and we'll know that as we go into the winter period, there'll be other schemes and initiatives that are identified that we can allocate remaining kind of monies against, but again, all for spend by the end of March. And just to say, obviously, and I think I've already said this, but we have got very specific conditions. So all of the monies and the reason for the different schemes or initiatives are because it has to be very specific and allocated to discharge from hospital. So just, and again, I won't kind of go through all of the individual schemes in the paper, but just, again, just to kind of emphasise that point, ward-based reablement is one such thing. We know that a number of people actually leave hospital or would be able to leave hospital earlier if they got more detailed reablement whilst on the ward. So through the additional reablement through therapy on the ward, we're hoping that that will enable people to actually be able to leave those hospital beds sooner and actually get home or into an intermediate care facility quicker than some people do already. The same as additional adult mental health practitioner capacity. Again, we're kind of relatively short or thin on the ground in terms of capacity for practitioners. And again, the danger is that we haven't got practitioners to go out and see people. They end up kind of in A&E waiting for a hospital bed as opposed to getting the adequate care that they need. So again, that's directly linked to discharge. And then a number of kind of other funds which are under 3.3.3, which you can see are again things that we've identified that we think will make a difference in terms of being able to discharge people from hospital. And again, they link to providing incentives to our providers to be able to actually deliver additional capacity and kind of being able to actually take people from hospital obviously quicker. We know that we often get a bottleneck from hospital into community because we don't have the domiciliary care capacity. So there are a couple of initiatives linked directly to that, which is kind of totaling 250,000. And again, we think things like increasing the by your side funding, which again makes sure that people's homes are ready for them to come home into. For example, that they've got heating or food, or just that there aren't any issues in terms of them coming home. Again, makes an enormous difference, and that's commissioned through CVS. So we're hoping that actually some of these funds will make a difference in terms of being able to get people home and keeping them at home when they are actually discharged. I don't intend on saying any much more because you've got the paper and you might have some questions, but just really the recommendation is that you sign the paper off so we can actually submit the spending plans by the 16th of December.
Thank you, Kerry. Do members have any questions? Councillor Ralph?
Yeah, can I just ask, in practice, what does the mental health discharge support look like?
Is that the AMPT one?
Yes, yeah.
Yeah. So, and again, colleagues might come in and give you more detail on this than I am able to, but adult mental health practitioners are able to kind of go out and assess people when they're actually, and I know you probably know this, in terms of kind of potential of being sectioned, etc. And actually, we've got a shortfall at the moment in practitioners. So we're hoping that actually this additional money will enable us to get those practitioners in place so we can facilitate quicker people who either are actually ready to be discharged but where they can't be assessed as such, or actually people also in the community where actually, because we haven't got maybe a practitioner to go out, they're actually then going to A&E because we can't get someone to go out quickly enough to actually go and assess them and get them into an appropriate place for that individual. Is that enough detail? I can always get back to you and give you more detail on it if you want, but is that enough for you at the moment?
That is exactly what I wanted to hear. Thank you.
Any further questions? No? Well, thank you, Kerry. I know it kind of strikes me, I wonder why we get put under pressure, because we all know winter's coming, it comes every year. Does the criteria change each year? Is that why we have to wait to see how we're going to plan what we can do? Or can we think about plans and kind of be proactively have them held there ready for next winter and then sort of expand on that? I'm not quite sure why we all get caught out by this.
Yeah, I don't think it's as much as kind of having plans, because I think we kind of know the general nature of kind of what's going to come down the line in terms of what it's for. Yeah, the conditions do change, so they don't exactly replicate year on year, but they do tend to focus on actually hospital beds and getting people out of hospital to free up those beds actually into the system. But it's obviously a whole system issue, because actually if you don't obviously kind of, you know, put money into for example, domiciliary care, you can't get people out of hospitals. And as we know, staffing and recruitment is a huge issue anyway. So we always have a number of things in mind that we think that we can spend the money on. I think the issue is the speed at which we have to spend the money. So a number of things that we might want to spend the money on take longer maybe than the time in which the money has to be spent. I mean, Stephen might have some other kind of, I don't know with Stephen whether you feel that I've kind of given that as an adequate response, but yeah, so the difficulty is then obviously coming up with the things that we know will make a difference, but in a very, very short period of time, and that's where the challenge comes.
Stephen, you had your hand up. It's gone down. Is that because Kerry's covered it? Would you like to comment?
No, indeed she has. She's covered it. We're never guaranteed this every year, but we usually get something. The issue, we never know how much. And of course, the last few years have been largely tied to COVID as well, and disentangling all of that. So we didn't know how much we would get. And I think we are able to call upon schemes that we know have worked in Thurrock in the past or have worked elsewhere, or a good practice that we can call upon quickly. You know, ideally we would have had longer lead into this for more planning, but actually when the council and MSC met yesterday, so on Wednesday, sorry, we were all on the same page about what needed to be done is to get this up and running and spent as soon as possible. And I think what we've got, planned should make a positive difference. So I'm happy with what Kerry has said.
Thank you. And yeah, I mean, we've got some great experts, both sides, health partners, yourselves and local authority. You all know what to expect come winter, apart from those added little things like COVID that knocked us sideways. It's recommended that members sign off the spending plan for Adult Social Care Discharge Fund 2022-23. Following sign-off and submission of the spending template, this funding will be distributed to both local authorities, integrated care boards to pool into the local Better Care Fund. In line with the usual Better Care Fund requirements, the use of both elements of this funding is to be agreed between local health and social care leaders. Are members content to approve the recommendations?
Agreed.
Lovely, thank you. Agenda item 4. Declaration of interest. Do members have any declarations of interest for future items? Councillor Ralph.
Only that I am Thurrock's Governor of EPUT.
Thank you. So we're going to take agenda item 7 first, the initial health assessment report. If Janet and Helen, if you would like to present your report, that would be great. Thank you.
Thank you, Chair. So this is a report following the last Health and Wellbeing Board, which looked at the...
Could you just move your microphone down a little bit?
Sorry, which looked at our performance around initial health assessments for children who are looked after by Thurrock. So I've come here to present this with Helen Farmer, and this report, I won't go through the whole report because I'm hoping that everybody has had an opportunity to read it, but it's really summarising our performance in relation to ensuring children get initial health assessments. So in summary, all children who come into the care of the local authority are required to have an initial health assessment. Those health assessments should be done within 28 actual days, 20 working days of the child coming into care. So there's 3 steps to this process. The first step is that the local authority should make a referral to health to request an initial health assessment, and that should be done within 5 working days. The second step is that the health organise the initial health assessment to take place within 20 working days, and then finally for the report to be submitted to the local authority so that we're able to plan for the healthcare needs of our children. Nationally, there's an issue around initial health assessments and getting those done in timescale. But in Thurrock, we've been working on this for some years, since 2019. We have had some initial improved performance, but the performance as it is today, we know isn't where it needs to be. So we've been working with health to look at how we can resolve some of those issues. So there's some system issues in terms of how we are managing that. So we're looking at that, and at the moment, so what's happened currently, we're looking at how we can improve it. So some of the actions that have been taken is that in the last few weeks, I've taken over chairing the weekly initial health assessment meeting with health colleagues of a similar level as myself, to make sure that we're kind of getting a real grip of that. And how we're doing that is looking at, well, what are the reasons why children are not having their health assessment needs met in time, both from the local authorities' perspective and from health. And I think we both recognise that the issues are not simply health or simply social care, but that there are a number of issues. So it's about what can we do jointly to make that work better. So one of the things we've done, as I said, is I'm chairing the weekly meeting, and what we're looking at is how can we make sure those referrals are done in a more timely way. So one of the things is where we know a child is coming into care, is making that referral prior to them entering the care system and not waiting. And just because we have 5 days, that we don't need to take 5 days always to make a referral to health. Making sure we're more robust with our paperwork to make sure that it doesn't get sent back to us because it's incorrectly completed. And also thinking about when an assessment is arranged, that we think about all the ways we can absolutely make sure children are able to attend. So having conversations with parents much earlier, inviting parents along to the initial health assessment, that the social workers need to be more proactive in making sure they're having those conversations. And just sort of having those general conversations about some of the things, some of the conversations we're having, for example, is if a child is coming into care, we have an example of one that's coming this week, and we know the child is coming into care, it's planned, we've made our initial referral, and the conversation is, well, we can't accept it because the child isn't actually in care. So those are the conversations we're having. We're recognising that there's system issues that we need to sort out between us. So we're trying to have those conversations. Where a child moves placement, do we necessarily have to reorganise the health assessment, or can we still go ahead with it rather than cancel it and rearrange it? So those are some of the things we're doing. And I know for health colleagues, I mean, Helen will be able to talk more about this, but some of the things they're doing around improving capacity, because that's a big issue in terms of getting the health assessments completed in timescale. So I'll hand over to Helen.
Thank you, Janet. Yeah, so just following on from Janet, there's been a focus on the process, but we also recognise from the referral being received, we've also got a capacity issue. That capacity issue is something that's recognised nationally. The initial health assessment does have to be taken by a medical practitioner trained, so it can't be a delegated responsibility, and so therefore we're reliant on a paediatrician with the right qualifications to actually carry out that assessment. We have got an issue with workforce and recruitment at the moment, which is one of the factors, but alongside that we also have a number of children that are not the Thurrock responsibility, but other authorities' responsibilities being placed into the areas of our providers. So about 70% of children seen by our provider is actually from outside of the Thurrock location, and that's putting a huge pressure on the available capacity that we have, so that we know that we have commissioned a sufficient capacity for Thurrock and for our areas. But in the last year in particular, we've seen a huge increase in the number of children being placed into foster care or other accommodation from other boroughs such as London and wider, Kent, etc., that we then have to meet the needs of and provide that initial health assessment, which is really absorbing our current capacity. So what we've done, we used to before, I think leading up to from the 2019 report, we used to spot purchase on an individual basis where we knew that we weren't going to meet the timescale required. We've now moved to a much more sustainable commissioning approach. So at the beginning of the year, we worked with NELFT and we provided and approved the ICB, or CCG at the time, approved additional funding for NELFT to recruit on a bank basis to have that flexible operating model. Unfortunately, that hasn't had the desired impact on performance, and it's continued to be a struggle to recruit bank or locum paediatricians to carry out that task. So we've reviewed that commissioning arrangement now with NELFT, and what we've agreed as a Mid and South Essex ICB is that we're going to commission additional capacity through an alternative provider, which our local providers will be able to draw down on to ensure that every child meets their statutory requirement. That's those children belonging to and under the authority of Thurrock, but also all children, all of our children placed in our area, irrelevant of where their host council are. So we've done a business case, and that's gone to our exec team this week, and it's been approved. So we'll be enacting that, going through a short due diligence process, and those IHA additional capacity will be available from January onwards. So we're hoping that will make a real impact on the timely delivery and give our providers across all of Mid and South Essex ICB and in Thurrock in particular, that's under significant pressure, that ability to draw down additional capacity when needed on a case-by-case basis without having to go through unduly sort of long sort of administrative approval processes. So that's where we've got to. Janet and I will continue to oversee and monitor the situation really closely and work with our partners in social care and health to ensure we sort of deliver the health assessments within a timely frame line. I would reiterate that the initial health assessments are a very formulaic kind of process. They're there to support the onward planning for that individual child, but any child can receive health care irrelevant of their need. If they require health care from a GP, emergency care, community services, it is not dependent on the IHA. So we are not restricting any health interventions because of the delay in IHA, and I just wanted to make that clarification for assurance. Thank you.
Sorry, could I just say one further thing? So in terms of initial health assessments, I would want to reassure members that all children receive an initial health assessment. And we've done some breakdown in terms of timescales, and 85% of children who require an initial health assessment are done within 56 days. So within, you know, I'm just sort of to be clear that we're not talking months and months, so that all children do receive one, but it's about getting them to have those received in a timely manner.
Thank you. Members got any questions? Councillor Ralph, you don't need to put your hand up and again have a question.
Thank you, Chair. I don't envy your task. I know the shortage that we have with paediatric care within the borough and across the nation at the moment. I guess my concerns come from we put these other children coming into our service. And I don't want to say that, you know, prioritising our own children. Every child is equal. But that do you get a heads up of how many children are going to come into the system? Because it must just be like, just as a flip of a page. So how do you plan ahead on something you don't predict, you can't predict?
Thank you. It's a very good question, and that is the problem that we're facing, is that we have to have an operating model, or our providers have to have an operating model that can flex. So some weeks we could get, so one of the weeks recently, Sharon was sharing with me, they had 16 referrals in 1 week. Our average across the month should be around 12. So suddenly you have to find additional capacity. We don't have paediatricians sitting twiddling their thumbs waiting for children to come in, and that means then cancelling other clinics to meet the statutory need. Now our advice, our guidance, national guidance, is that a statutory timeline should never take preference over a clinical need, and I think we'd all agree with that principle. A clinical need is always a priority, but it's not a good experience for any of our families if we're cancelling clinics, etc. So that's why we've gone to this new commissioning model where we have a provider quite local to us actually that has capacity in their paediatricians, who has a different commissioning model that we can just pull down when we need to without the disruption to the rest of the service. And I think that moves us away from a reactive service and commissioning arrangement to a proactive one that allows us to respond appropriately. We know this is the model we need to do. It's not going to change now, but it allows us the flexibility. NHS England wrote to all providers and ICBs at the beginning of this year, issuing a clear statement that no matter whether the child is in your area or is placed in your area from outside, the provider has the responsibility locally to deliver the IHA. There had become a practice because of the national pressures that areas were saying we're going to prioritise our own children over others placed in. We never took that stance as a CCG back then with our providers. We took every child from their need, irrespective of the arrangements around their care. And I think that was the right ethical thing to do. And I'm glad that we've now got national backup to do that, and that when Thurrock have to place their children outside other areas, we chase those, we monitor that. We can bring them back into the areas, but equally we do expect our other providers, if they're in Kent or Manchester or wherever they might be placed, to be doing and acting in the same way. So it's a very good question. Thank you very much.
Thank you, Chair.
Councillor Lydiard.
Thanks for your report. As a former foster carer, I've always been very pleased with the proactive way that Thurrock's dealt with health assessments. I know we're looking at, days missed and things like that. Is there any other way of measuring the failures, maybe in serious cases? Because the number of days missed is probably not that meaningful to me.
I think what we're doing now is that actually we're doing almost like a root cause analysis for each child where they're missing. Because the numbers are relatively small, the weekly meeting will track each child. If there's there shouldn't be any clinical risks, because healthcare should be sought irrespective of the IHA. But obviously, ideally, when the authority is planning with the independent responsible officer for the forward care of that child, the whole picture is needed to ensure that we're meeting that child's needs in totality. And that's the importance of the timeline. So we're tracking each individual child, seeing if there's anything we can do, and as you say, sort of doing that root cause analysis for every individual child that comes through our system.
Any further questions? No. Sheila, you go first.
Thanks, Chair. I mean, I welcome this report, and I think from the last conversation, we've got a bit more depth about what the issues are and also what we're trying to do to resolve it. And it's really good news, as far as I'm concerned, to hear about this alternative provider and a little bit more flexibility about how we do that. I think what we're all working towards is that children should get their initial health assessments done in a timely way. Statutory requirement is 20 working days. We should be targeting that and aiming at that. And I know a lot of work's going on to make this happen. But I think having had the oversight and challenge from Health and Wellbeing Board, it has actually helped the system to be able to prioritise and make sure that this is given the needs it's given. So I suppose I would ask the Health and Wellbeing Board to keep oversight of this particular issue for children.
Yeah, funnily enough, I came to that same conclusion, and I've got some changes for the recommendation, to be honest. But before that, I welcome and thank you for coming back with a much more thorough, in-depth look at the issue. As Health and Wellbeing Board, we want people to come forward if they've got a problem that it's not working how it should, and if it's not highlighted to us to be able to look at it and challenge it with you and support, then we can't move these things forward. So I would ask anyone to bring things to us to add to the agenda or for urgent items of business if they feel that the board can help. For me, the report, I did mention this, Janet, that it still feels kind of lacking on the reasons. And when this is, it's going to sound very critical, and I don't mean it to, so I'm going to apologise, but I'm just going to kind of like throw my thoughts out there, and then you can reassure me, and I'll understand better. But we've been having delays since 2019. You've been talking about these things at weekly and monthly meetings for 3 years, and yet we're still talking about what are the reasons. And I kind of wanted more in the report to understand the reasons now, because obviously if you don't know I know you're working on it, but if you don't know where those issues are, how are you going to put them right? So it kind of seemed fundamental to me that this would be already being done, and perhaps it is, and it's just not coming across in the report. And when we say about workforce and recruitment and capacity, we're focusing on the now, but there's been issues for 3 years around capacity and workforce. So yes, I'm really pleased to see that it's having focus, but I wonder why there wasn't focus before, because this is pre-COVID. I understand COVID would have been an issue and it would have been very difficult around that time. But we're talking about 2019 as well here. And then you were saying about capacity. Helen was commissioned for Thurrock, and then I fully appreciate exactly what you've explained here about children from outside and prioritising and doing that correctly. But it almost feels like it was to detriment of what was commissioned for Thurrock, rather than increasing capacity then to deal with outside. Capacity was moved, and that is probably fundamentally, for me, in a naive way, feels like that's where the issue maybe started.
So in terms of, yes, we've been addressing this. So when we had our Ofsted inspection in 2019, one of the recommendations was around improving the timeliness of initial health assessments, and a lot of work went into it, and we did see an improved performance. And I think it was improving up until probably around COVID, when COVID hit. And then that had an impact, I would say. I don't know if Helen would agree, but that had an impact in terms of initial health assessments. And I think some of the reasons for the delays now are slightly different from the delays in 2019. So when I joined in 2018 and 2019, we were looking at really having systems, clear systems in place, just basic systems in place to make sure that initial health assessments were being met. And we had lots of conversations with health, we developed forms, we developed systems, and we actually were getting to a good place. You know, we were doing something like 90% in time in terms of referrals. The numbers of initial health assessments had gone up. I just was quickly looking. So if Helen's talking, I'll be able to get you the actual data, because we do have it on the system. So we did have better, and but it has declined. And so when I'm looking at it, and I've taken on board some of the conversations we've had, and I've looked at some of the reasons. And so the only acceptable reasons for me for a delay in a referral from children's social care is where it's a Section 20, so a parent has refused to give permission and they are in that position where they can do that. For me, that's the only acceptable reason for why it should be late from children's social care. So what I'm seeing is that there's been some delays in children's social care, so it's about making sure the paperwork is right, but also having a conversation with our health colleagues about, okay, we missed a date or we missed something, that shouldn't prevent the health assessment from being arranged, but it's about having a relationship with our colleagues and having those conversations. So I think, we have gone through some of the reasons why it not be. So it might be something like a translator isn't available, but you know, if we've got plenty of time to arrange that, we should be able to organise for somebody to interpret for an unaccompanied asylum seeker. When unaccompanied asylum seekers come into care, as we do their paperwork on the first day, we should be doing the health request. Just because we have 5 days, we don't need to take 5 days. So those are some of the messages I'm giving back to social workers. And where we do have Section 20 of the Children Act, where parents need to give their consent, we always ask for consent, but if it's Section 20, we can't go ahead without it, is that we should be having those conversations much earlier on with parents. If I look back to my own social work days when I was doing direct social work, the conversation I would be having with parents is, you know, most parents want their children's health needs to be met. They want them to be safe. They want them to be okay. And so the conversations I would be having is explaining what we're asking and saying, look, we want you to be there. We want you to be there alongside us when that health assessment, you know your child more than we do. You can give those explanations to the health professionals. And so it's about trying to identify those issues, as you said, and kind of addressing each one of those and making it tighter. Because there really are no major reasons why it should be late from children's social care. Helen can talk about, you know, from a health perspective, but actually there is no clear reason. And we were at sort of 80 plus 90% with our referrals at one point, so, and that's not quite where it needs to be, so we're working on that.
If there's time, just to say yes, I think the reasons and the rationale for the challenges has changed since 2019. So we've seen improvement in one part of the system, and at that time it wasn't a capacity issue for us. And then in the last year, it's become more of a capacity, and social care, have streamlined their process, and that's why we've gone to a new commissioning model. I think we have tried something. So in response to the kind of the criticism, why haven't we acted sooner? We tried something. We did invest more. That model of commissioning didn't work, or we weren't able to deliver. And the recruitment and the changes in placement are issues outside of our control in many ways. But we're doing our best to address those.
Thank you. Yeah, I know we can often be seen as criticising, and it's never really meant as criticism. It's always coming from a place of wanting to understand better ourselves, seeing how we can maybe help, support, or throw in ideas. I know we're not the health professionals, but sometimes that's where you get a bit of out-the-box thinking that might just spur something. And for us, it's I would thank you for coming today and facing us, because it probably feels like that. But for us, it's about getting a much better understanding of all those things that you can't put into a report. So I do thank you both. It's recommended that members are aware of the continuing performance issues with initial health assessments and the action being taken by Children's Services and NHS. Like I said to you, Sheila, to be honest, I'm not completely happy with this recommendation. We've known for a couple of months now, we've noted for a couple of months. It's a continuing problem which you are now working on, and there's some real good stuff and proactive moves coming out of that, which is great. But we do have to bear in mind that this is a legal statutory requirement. It's not just an item on Santa's wish list. So we need to find ways to get that improvement. And I'd like to suggest that this comes back to Health and Wellbeing Board in February as an additional item. So it gives 2 more months to embed some changes. And what you've got going on, Helen, in January sounds really good and very promising. So it would be really nice to hear how that's doing. Councillor Ralph?
Thanks, Chair. The only thing that strikes mind is that coming back in February, because it's such a flexible and fluid situation with how many children you get, we may not get a true over picture, because I may not get that many come through in that time. So I don't know if we can maybe extend it over a couple of months or something.
I'd like to be saying that we look at it in February and then we decide in February if we look at it again in March or April. I just think if you've got some stuff going on in January, it would be nice to know that's happened, that's starting to be embedded, and what changes that might be making for you, and then perhaps, like you say, look at it again later in the year. Janet?
That's fine, we can bring it back in February, but I would sort of say that in terms of the data, it's usually a month behind. It's a good month behind, because the initial health assessment isn't actually complete until the report is back with social care. So it is always behind. But just quickly going back to performance, because I know you were saying this has been going on, and it has been going on since 2019. So when Ofsted came in November 2019, we were at a low point of around 44% of referrals being made in time. And we'd kind of improved. It went to 66, 73, 85, 100%, 86%. So you could see the movement. And then you can see as we go into COVID, that it gradually starts to, we managed to maintain it until COVID really gets at its worst, and then it starts to decrease. That doesn't take away that we need to make sure our performance is better, but it's just to say that we have been at a point where it's been higher. It hasn't been a low all the way from 2019.
Thank you for that clarification. Yeah, let's make it March then rather than February. I think Councillor Ralph, thank you for pointing that out. And I appreciate that it takes a while to get a bit of data. Does that suit you, Helen? Would that be okay? Do you think that's enough time to see if it's making a change for you?
Yes, definitely. We should have an update and be able to update how the new provider is delivering and how those protocols are working. So it might be more descriptive than data, but I think, you know, I welcome the scrutiny and the support of the board. So thank you very much.
Thank you. So Claire, can you make some changes? Thank you. So moving on to agenda items 5 and 6, health and wellbeing strategy, domains in focus. As chair of board, I've been particularly keen to ensure that we have robust reporting and monitoring of progress against commitments made in the health and wellbeing strategy. For year one, I agreed in recognition that the strategy was launched in July that reports should provide a summary of domain and priorities and setting out plans for delivery for once a year. For year one, sorry. From year two, we'll focus on what's been achieved during year one and our next steps. And a covering report for both items 5 and 6 is provided at page 15 of your papers. And a supporting report for domain 3, personal-led healthcare, is provided on page 27. 20 minutes has been provided for this item, comprising a 10-minute presentation and 10 minutes Q&A, and I'd like to ask Kerry Armstrong to introduce Domain 3, Person-Led Health and Care. Thank you.
Thank you, Chair. Domain 3 is person-led health and care, and just want to say that the domain is inextricably linked to our adult integrated care strategy, and you may remember that I brought a paper and the strategy to the board a few months ago now, I think, where it was endorsed and agreed. So this is all linked to the delivery of that strategy. And there are other domains within the health and wellbeing strategy that also link to that. And also the other point I just want to make before kind of going into some of the detail, and again, you've had this in your pack, so I won't read everything out, is that a significant amount of work is already taking place on this, and this builds on previous transformation work that has already started, so we're not starting from a low base at all, but building on that, which is always positive. So in terms of the actual domain, just a bit of an overview. So you'll see the kind of the aim and the ambitions in front of you, but really, in essence, it's around kind of the ability for us to deliver better outcomes for individuals, and actually us using our existing health and care resources in a way that best does that. And we think that the majority of that is actually achieved through working at place, reflecting kind of the differences of people in place, so very much around kind of what different communities and different kind of cohorts of people are wanting, and actually integrating across the system, so not just adults and health, but also other service areas such as housing, to deliver an approach which is actually around the person, as opposed to expecting the person to actually go to a number of different, often fragmented services to try and get the solution that they require, and often not achieving that, or achieving that and meeting their needs and conditions, but not necessarily having a better well-being. So it's kind of no easy task, really. And then there are 4 domain goals that make up Domain 3. So 3A, which is around integrating health and care services in Thurrock. So really, that's the essence of our strategy. 3B, which focuses on how we deliver that through our primary care response, and Stephen's going to talk a bit about that because he's got the detail. 3C, which is around how we can move our workforce to deliver the ambition that underpins Domain 3, and 3D is around how we commission, because there's one thing about developing and changing and transforming provision, but actually if we don't have a market that will support that, and if we can't commission the market to support that, then actually we won't achieve that aim. So the essence of kind of how we shift our current commissioning model to one that's more integrated and person-centred is of ultimate importance to us and to achieving this domain. So I'm going to move on to just 3A and just describe a little bit about what that's about and what we're doing. And again, this is really overpinning in terms of how we move to a more integrated health. And it's not just to say, oh, even though it says health and care, actually it's more than health and care. It's also around how we think about the other things that people need in their life in order to live a better life. So whether that's housing, whether that's around kind of helping to manage debt, whether that's around social inclusion and preventing isolation, etc. All things that actually lead to someone having a good well-being, and also leading to whether someone actually needs health and care support is pivotal to this strategy and to the delivery of this strategy. There are some key challenges which are identified there to delivering that, and again I won't go into lots of detail because it's there in front of you, but obviously, you know, some of the things around kind of actually how we change our existing culture, a culture that's been built up over the last kind of, you know, number of decades, isn't an easy task. Obviously, there's always a resource requirement involved in massive or significant transformation programs in terms of how we invest in, you know, experimenting with new initiatives, how we kind of get the resource in order to actually deliver. That is no easy thing in today's climate. And just obviously, you know, as we all know, a number of different organisations around the health landscape, you know, the new integrated care board, how that links in with our place-based focus, all of that, you know, it is added complication that we need to navigate our way around in order to achieve goal 3. So I'm not going to go into kind of much more detail. I'll just say that obviously in terms of what we're hoping to do differently, a number of people at the moment have a very fragmented experience of health and care, particularly when they have well, we describe them as complex, but actually I think we've made them complex a lot of the time. So they often have to go through a number of different front doors in order to try and get what they need. What we're trying to do and what we want to be different is that people don't have to go through different front doors, that we don't do numerous onward referrals in order to get people what they want, is that they often go through one front door and then we're able to deliver a coordinated response which focuses around what people want their lives to be and what they want to achieve. We need to empower our staff to do that and to do things differently, so having different conversations, having a very different starting point, empowering them to find different solutions. And we need to obviously change our system to be able to support that. The other thing is actually, and I've alluded to this already, is actually moving from a focus on needs and conditions to be very much focused on well-being and actually how you achieve that with the resources that we have at our disposal. Again, it's a very different way of delivering health and care. In terms of 3B, I'm going to invite Stephen just to say a bit about that, if that's okay, Chair, in terms of the primary care. So, Stephen, over to you for 3B.
Thanks, Kerry, and I support everything you've said there. I'm just trying to get it on because I'm flipping between screens to do this, so please bear with me a second. So this obviously is about improved primary care response, including timely access and reduced variation between practices and access to a range of professionals. So at the HOSC last time, I talked about the underdoctoring in Thurrock, where the second, Thurrock's the second lowest in England per 100,000 for doctors. I think we've got about 40, 42, something like that. And obviously we need to try and encourage GPs to come and work in Thurrock. So the access is going to be largely predicated on that. I'm not going to go over that whole issue again here because of time, but we are coming back with that in the new year, I think, to this, as the Chair said. And there's a range of initiatives we've got to try and improve access. And they will include 31,000 across MSE. This is new telephone lines. We need to sort of be doing a piece of work at the moment to see how that breaks down for Thurrock and how that's going to be. But I think the thing in terms of access as well, it's around some of the things Kerry's already said, that there shouldn't be no wrong door for people when they need to see somebody, and should get the appropriate referral, whether it's through a GP, through a nurse, for somebody else. If somebody needs to see a doctor, they should see a doctor quickly and same day in urgent cases. But occasionally there'll be other professionals that can help for less serious conditions. And it's about supporting care navigators in GP practices to be able to make some of those calls in consultation, obviously, with the patient. So we need to look at primary care access that includes a mixed skilled clinical workforce with the delivery of new ways of working. And those new ways of working, again, for time I won't go into detail, but are described in the Thurrock strategy, Better to get, Care Together, Case for Further Change. And basically it does allude to the fact that we need to remove some of the barriers that people have traditionally faced to access the right services and supports. And in terms of addressing quality and variation and being more preventative and proactive than reactive, each of our primary care networks by March will have their own clinical strategy, which we're working up locally, including with our clinical director, Manjeet Sharma. So that will hopefully address some of that stuff. And of course, we've got the Corringham's now open, and that's an opportunity to demonstrate really and to show how we can truly work in a collaborative way, in a co-located way, so that people who access services through there should find it more seamless, and there aren't any other doors to go through, and there'll be interesting developments around that in terms of pilots for obesity and other stuff as well that we know in terms of our population health data are real challenges for Thurrock. So the focus is going to be on well-being, getting people the right services they need as quickly as possible, and obviously trying to address the shortage of GPs in particular that we have in Thurrock through it. We've got a range of activities and initiatives planned to address that, which I did go into some detail with at the HOSC. I think I'll probably leave that there, Kerry, if that's okay. If there's any questions, obviously, be pleased to try and answer those.
Thanks, Stephen. This really is a whistle-stop tour, so I'll I'll carry on. So kind of goal 3C is then around kind of actually how we deliver a very different type of workforce, a workforce that works to place and not to a lanyard, I think is how we want to best kind of actually describe that really. So, and again, that's all around kind of actually changing the culture of how you view yourself and how you kind of view what you do when you work with people. So, for example, we're delivering things that we're calling blended roles. So rather than actually just going into someone's home potentially to maybe deliver healthcare, then maybe actually you'll be actually also assessing someone for some occupational therapy equipment. It might be that if you're actually delivering some home care, you can also deliver some low-level some health tasks. So actually you're also releasing capacity for health specialists, but also avoiding someone from having lots of different professionals coming in and providing more of an integrated service. The same as when Stephen was saying, actually people might come into a building like Corringham IMC, actually to see a GP, but actually there might be other people that you need to see there and then, which means you can get that integrated solution as opposed to having to, say, be palmed off to a number of different professionals or organisations. So there's a lot going on in this. I mean, some of the difficulty will be actually communicating those changes to individuals and showing them that we're not actually diluting the care that they're going to receive. So actually that it's not a bad thing that maybe, you know, if you go in and you want to see your GP, actually the best person to see you may not be the GP. So that's actually a change of hearts and minds really that we're going to have to work on just to actually, really support people and give them confidence that actually we will give them the best person to deal with their situation in the best way. I won't go on too much more because I know I've just got the 2-minute warning, but there are a number of things that we're already doing and will grow on. So I talked about blended roles. We've got a number of different experiments in place to try and shift our culture and to understand what we need. So we've got some, we're calling them link nurses, but we've got nurses working in place alongside a number of our professionals to try and build those relationships and to understand what each of us could actually do in addition to maybe our specialism. So how we can develop more and more blended roles. And again, being co-located and having different conversations with people in place is already leading to more integrated solutions and actually less referrals. So building on all of that is going to help us to move in the right direction. There's obviously far more than that, but that's what we're doing at the moment. Just finally, and again briefly, I mentioned about the importance of commissioning and delivering a very different commissioning model. Again, if we need to kind of move away from that commissioning to time and task if we want to commission a system and provision that actually looks at the individual and delivers something that's more personalised to that individual. So actually, so we're already, and again, we're probably a bit further behind on commissioning than we are on kind of provision experiments, but we're actually starting to do some thinking around that. So actually having a very different market development strategy, working with existing providers to actually involve them in communicating that change, thinking about what communities themselves can do as opposed to what we commission other services to do. Actually thinking about how we could bring budgets and governance together across, whether it's across adult social care, with housing, with health, so we have more of an integrated approach as opposed to us going off and commissioning our various bits in silo. And actually just making sure that within our specifications, we actually build in a lot of flexibility. So we're not so specific necessarily about what we want providers to do, but actually, we actually almost commission for learning. We expect providers to go out and think about what's required with the people that they're actually delivering the service to, and actually be able to develop through the money we've given them, the best solutions. So it's actually very much kind of iterative and kind of growing from the ground upwards. I think I'm going to stop there. I've probably spoken far too long. I could probably speak all day about all of this, but if there are any questions, happy to try and respond to them.
Thank you, Kerry. Councillor Ralph?
First of all, Chair, are we covering the other domains on this one as well? Or are we just sticking with the first domains that we've covered? Because item 5 and 6, it was both on them.
Joe's going to present on the other domain, so.
Okay, thank you, Chair. Yeah, I don't want to sound like a broken record, but you know what I'm going to say about GPs. At the moment, we've obviously got a severe problem with our GPs and that recruitment style of how we get them to come here. But it doesn't just seem to be that. I know at the moment, and I've tested this myself, for a child to get a blood test in Thurrock is now February, the end of February. And that just seems unacceptable where they can go to Southend to get it the same day. Is there reasons why we're falling back on that? Is there a blockage in our system where it comes to the children? I know obviously they've got to be at a different location. Thank you, Stephen.
I think Stephen's got his hand up to I'm not quite, well actually I am sliding to Stephen, but I think he's got the better response if that's okay,
So
Chair.
that's a very timely question, Councillor. We've got a meeting about phlebotomy. I think if it's not next week, it's the week after. It's before Christmas, because I've had some queries from members around the pause in phlebotomy services in South Ockenden, and we are working now to try and get those reinstated, which should help go some way to address that issue if that's what people are experiencing, and I would be concerned. But notwithstanding that, I will use that meeting to make inquiries about the appointment waits, and if indeed they are, as you say, I will ask the Commission services to come up with a solution over and above, if there is one, to reinstating phlebotomy services in South Ockenden if we can overcome a few issues which they have raised. But that's certainly a welcome comment, and I will take that into that meeting.
Thank you, Stephen.
Thank you. Thank you, Kerry. I know you're very passionate about this, and I know you know that I am. And there are many of us that have friends or relatives requiring care and support that have struggled to be heard and found it difficult to make changes to packages as their circumstances have changed. So I welcome the work that's being done. I suppose for me, one of the questions is that this is a huge culture change for those working within this area of care. For staff, I would think, from being told that's not your job, to now probably seeing for a very long time that they could have done more and they've been stopped from doing that, to reverse that's a big job for everyone to sort of take on. How is it going? How do you plan to do that?
Obviously, as I said, I think at the start of the presentation, we've been embarking on transformation for probably more than a decade in Thurrock. And the approach we've always used has been one where we've actually, everything we've developed has been alongside staff. And actually, that's key to embedding the change. And what we've always done is actually started small, invited members of staff who are actually, again, enthusiastic about being the pathfinders to get involved and to actually go and test and learn. So before we've actually said, this is how we're going to do it, we've actually always experimented and always identified whether actually the change that we think is the right change is the right change, and is it going to work? And I think that approach has actually fared very, very well. So actually, with community-led support, for example, the way that we've changed social work, we started with one small team. By the time we got to the third and the fourth teams, social workers couldn't wait to actually change and do it as well. So we've found that actually the fact that their colleagues have actually been forerunners and actually have kind of tested and actually changed the model before other people have been asked to do it has actually made it okay for people and actually reduced any anxieties about that change. Yeah, I think there are things that we've asked people to do that have not necessarily been the right approach, and probably, mostly, practitioners have been aware of the changes they've needed to make far before we have. So I think I'm hoping that that our approach now in changing culture is actually going to be very welcomed by people, because actually they're the things that they've been saying to us for a very long time that they want to do. I think what we need to do is just make sure that we give people the confidence that we're not diluting specialisms and asking everyone to be generalists, but actually what we're doing is saying if there are some things you could do whilst you're there with Mrs. Smith, for example, why have another professional come in? You know, why have kind of 4 people coming in when actually you could do that, and actually you know you've got the relationship with the person already. And I think people understand that. I'm not saying it's going to be easy because it's massive change, but I think using that approach and building on that as we go through transformation will be the one that we continue to use, and it's the one that we've found has been most successful so far.
Thank you. I'm glad you put your hand up, Stephen, because I was going to ask you if you wanted to add in there. You're on mute, Stephen. We can't hear you.
Sorry, first time today, it won't be the last. Just to say no, that Kerry's right, and I think we have to be bold with some of these things, and actually we need to be not afraid of trying new ways of doing work and supporting people, but it's making sure that we get that feedback from people, that if it's working or not, if it's good for them, it's got to be good for the service users, the carers, the patients. So we do that. So on that level, on an operational level, we will try new things out, but also we'll talk about it collaboratively at the Thurrock Integrated Care Alliance, for example, which is a good place to talk about that, and the Better Care Together Thurrock groups as well, where the work streams, which are supporting the kind of practice that Kerry's talking about, gets discussed, and feedback from patients, service users, carers, sometimes via Health Watch, sometimes we get direct feedback, but it's really important to adjust according to that as well. But I think it's good to be innovative and to try and do things with putting the person at the centre of what we do, rather than just presenting them with a menu of stuff that they have to take or leave. So Kerry's right, and I think by breaking the work down into manageable chunks, as we're doing with the rollout of the phases of Better Together, I think it will be achievable.
Thank you, Stephen. Councillor Ralph, you wanted to come back in?
Yeah, thank you, Chair. I just want to say that I think we're on the right path. I know we're not allowed to talk about, we shouldn't talk about individual cases, but I was contacted by a resident. I was just going to check on the information, but I won't. They went to the Coronham IMC, and they were there for a different reason, and they were identified by someone that was working with them for another situation, mental health situation. They now got the support and booked in for sessions there. And at the same time, another thing was identified with them. So just by walking through that door of the IMC, they feel as if a new lease of life has been opened to them. And so I do think when it gets right, when it works, it really works. And I think that's the benefit of having the IMC, that there is no wrong door. And with everyone working together, we really have made an impact to that person's life. So I'd just like to pass my thanks on to that.
Thank you, Councillor Ralph. Did either of you want to come back in there on that?
No, I was just going to say thank you. I'm always slightly nervous when you've got your hand up as to whether you're going to say it's not working. Yeah, and actually it is as simple as just sometimes just actually making sure that staff are co-located in the same area and actually just get to know who's in their area and what they do, you know, because actually you might not, as a professional, you might not be able to actually, you might be able to identify that you think someone needs help with, for example, mental health. You might not be able to deal with it, but actually the fact that you know who does and you can pick up the phone there and then is actually sometimes all that it takes. And I think sometimes that's been missing. So what we are seeing actually, as we are developing a place-based approach and we are getting, you know, making sure that professionals know who else is in your area, get to know them, get to know what they do, it's hopefully making a difference. So there's the building, but there's also just knowing who people are. So hopefully, you know, you'll have more and more of those good examples that you can share as opposed to the ones that we don't like you sharing so much.
Thank you. Yeah, I mean, it is great. It's fantastic when it's working perfectly. But the times it goes wrong, they're our learning, aren't they? That's how we can continually improve, by understanding from that. But there is nothing worse than a resident having to repeat the same thing about their ailments and what they need to 3 or 4 people that come through the door over a week, and it's like, it feels like a huge brick wall, and it's lovely to see the work you're doing to break that down. And I mean that right across the Alliance and all health partners there. Thank you. It's recommended that members consider and comment on the plans. We've done some commenting for delivering the goals of their health and wellbeings in Domain 3, person-led healthcare. Are members content to approve the recommendations? Yeah, agreed. Thank you. So moving on to agenda item 6, Domain 5, housing and environment. An additional supporting report was provided at page 39 of your papers. Again, 20 minutes has been provided for this item, 10 minutes presentation, 10 minutes Q&A. I'm pleased to ask Jo Broadbent to introduce this item. Thank you.
Thank you, Chair. And I'm giving an overview on this item as Public Health have pulled together information from a large number of officers across the council, because this is quite a broad-reaching domain, and each goal is led by a different officer in the council. So I'm going to present an overview, but I'm really pleased that Evelina Sorbjan, as our Director of Housing, is here as well and will be able to help answer questions on the housing elements of this domain in particular. So this is one of the domains of the health and wellbeing strategy that focuses on the wider determinants of health, and board members will remember from the strategy itself that in terms of individual and community health, it's these wider determinants of health that really have the greatest impact on health status, over and above, for example, access to high quality clinical services. I think it's also really timely that we are looking at this domain now, as everyone will be aware of the high profile tragic events in Rochdale, where poor quality housing sadly led to the death of a young child. So I think it's really, really key that we're considering this element of the wider determinants of health as part of our health and wellbeing strategy, and timely that we're doing it today. We also have some particular challenges in Thurrock that contribute to some of the challenges in this domain, such as housing affordability, and we've tried to focus very much on those areas of challenge that we do have in Thurrock in this area. So the aims and ambitions of this domain, looking at housing and the environment, are broad. The first aim is to ensure fewer people will be at risk of homelessness and fewer people are affected by homelessness in the borough, and to make sure everyone has access to high quality and affordable homes that meet their particular needs. The second key aim under this domain is to make homes and places in Thurrock all environments where everyone feels safe, healthy, connected and proud to live. So we have some very broad and quite ambitious aims for this domain. The details of how we're going to deliver all this are set out in the underpinning strategies, and those are listed for all of the 4 domains the board has looked at so far in an appendix to the paper. But the key strategies that underpin this domain, I think, are the homelessness strategy, the housing strategy, the housing domestic abuse policy, the climate change strategies we have in the borough, and also the developing local plan. Those are really the key strategies. And the detail that we're highlighting today has all come out of one or other of these strategies. So as Kerry's just done, I'm going to go through the domains quickly and give a high level overview and then leave some time for questions. And there are 4 goals within this domain. So the first goal is about reducing homelessness and increasing the supply of affordable housing in Thurrock. And essentially what we want to achieve is all Thurrock residents having a secure, stable and affordable home for them and their family. So obviously identifying people at risk of homelessness and preventing homelessness is absolutely key to this first goal. We've done incredible things during the COVID pandemic, actually, about reducing rough sleeping and mitigating those effects. And we're really keen to build on the rapid progress we made during the pandemic regarding rough sleeping, but also supporting other people within the borough who are at risk of homelessness. And with the cost of living crisis, this is likely to be affecting a broader range of people. So under this goal, we've got 2 key elements that we're focusing on. The first is around temporary accommodation, reducing out of area temporary accommodation placements, and also reducing the time spent in temporary accommodation. And there's a whole range of actions that are needed to achieve both of those things. The other key area under this goal is around affordability, as I've mentioned, and we want to introduce a Thurrock affordability standard for future housing, establishing Thurrock affordable rent levels, ensuring that new units have the recommended level of affordable housing within developments, and also increasing council-owned affordable rental properties. So there's a lot in here, and this is all contained within the homelessness strategy, as I've said. Goal B is around good quality homes, and this is covering residents of council-owned housing, social housing stock, and also the private sector housing stock. So again, this is a very broad goal and very broad ambition. We want all Thurrock residents to be able to live in homes that are suitable for their needs, that keep them healthy and crucially protect them from hazards such as cold, damp and mould. So there's a lot of work going on around the council housing stock, and I have seen Councillor Arnold was out and about this week looking at some of the improvements that are being made in the borough. We know also that the social housing stock is generally, in terms of housing quality, better than the private housing stock. So focusing on both of these areas is going to be key. And we've got some key initiatives, particularly targeting the private sector landlords and utilising the Well Homes programme, as well as things such as increasing renewable technologies in the council stock. So in terms of what we'll do differently and how we'll level the playing field, we need to really be looking at how we use this Well Homes programme and ensuring that the programme reach priority groups within the community, such as people living with long-term conditions, people with other health needs such as mental health needs, and also people with learning disabilities. We're going to be focusing on removing health and safety hazards from the private rental sector and using the full extent of the enforcement powers that the council has. And we're doing a lot of work currently around fuel poverty related to the cost of living crisis. So this will include accessing green homes grants, energy improvements in the private sector housing, and incentivising energy efficiency of the housing stock through a variety of initiatives, including the grants. We've also got a particular project underway where we are trying to link our insight around challenges with the cost of living, challenges with fuel poverty, to high levels of need because of health conditions to enable that targeting at the moment. So we're looking at how we can link up some of our data to enhance the targeting of our projects to support fuel poverty, such as the financial inclusion officers that the housing team has. Moving on to goal C, this is a very specific goal around supporting people who are experiencing or at risk of domestic abuse and sexual abuse, and considering how to get them into safe and secure accommodation. We have a housing domestic abuse policy that is targeted at this, and so that the initiatives under this goal are very much linked to that policy that's led by the housing team, but obviously linking out into the wider support that's available to those who are experiencing abuse and violence of a variety of types. So the focus of this is to streamline support that's available, streamlining funding, but also providing a single point of access for individuals who are requiring support, to ensure that they have access to a range of housing options, as it's likely not just to be individuals, but families that might need to be rehoused at short notice, and to also improve public awareness that they can seek this support, that people in this situation can reach out, and there is support available to them. The final goal under this domain is looking at the broader environment, both the built environment, the green and blue environment within the borough. Public Health have been working with the place teams, particularly the planning team, the transport team, the environmental health team, and there's a multifaceted action under this particular goal. So just to focus on a number of the things that are underway. First of all, air quality. Air quality is perennially of high concern within our borough, and we know we've had challenges in addressing the update to the air quality strategy that's been needed. I'm pleased to say, though, we now have the air quality monitoring officer post filled. They are updating the air quality status report currently, and that will be published in the first quarter of the next financial year. Following that, we then have an outline plan to revise the air quality strategy, including comprehensive consultation, and that will be published in 2024. So we've now got a plan to take forward air quality. That was sort of paused, I think, for some time during the COVID pandemic. The local plan is also absolutely fundamental to achieving this goal, and there's a number of initiatives that Public Health are working on with the local plan team. Health impact assessments and how that's embedded into future planning activity is really crucial, and also the design principles that will underpin the local plan are really key to embedding health and wellbeing considerations in our future building and development within the borough, including things like ensuring green spaces and designing in community safety. We're also working with the transport team. The public health team completed an active travel needs assessment earlier this year, and this will be coming to HOSC and the Health and Wellbeing Board as soon as it can be agendarised for both of those, HOSC being in the new year. We've shared this obviously with the transport team, and public health are actively working with them on the transport strategy for the borough and how we can promote walking, cycling as active transport modes within Thurrock. And there's a lot of work going on climate change. The council obviously has the internal climate change strategy, but also the borough-wide energy and climate strategy. And that, again, is a very broad brush approach that will really impact on improving the environment for local residents, as well as more global climate considerations. And this domain really is about working with partners, particularly across this last goal. We can't do this alone as a council. So we're working with ASLA, particularly around green and blue spaces and access to those. And air quality, for instance, is a topic that needs to really be considered beyond the boroughs of Thurrock, and we need to work in concert with national agencies and also our neighbouring partners. So we've set out on the final slide, under this domain, some of the deliverables, and a lot of these are about completing the strategies and implementing the action plans of those underpinning strategies. And I'll stop there. Thanks, Chair.
Thank you, Jo. And Councillor Ralph, you're smiling.
Thank you, Chair. To be honest, we could be here the whole day and probably tomorrow debating over the items on here. These are words, and you never know how good they are till you have to put them into practice. Unfortunately, over the last few weeks, I've had to deal with a complex case, another case that was done absolutely fantastically by officers, and a sad case. The first case was very complex with someone that was in harm, that threats made against, and it became very, very difficult. It's ongoing. And I understand, we had to get the CEO involved, So I think these systems work when they can be quite simple. When they get complex, they get quite tricky. So there's a lot of police notifications involved and everything there. So I think that sometimes when we look at that, there's understandable why things do get complicated. On the other one, I was sitting just back there on full council. I got a text about a homeless man in Corringham. He was 70. And your team homed them within 3 hours into one of the hotels. Absolutely fantastic work. And on the other one, a gentleman that was suffering domestic abuse. Can you confirm that we have no male shelter refuge in Thurrock with like-minded people where they can feel safe? I know when we've got the female shelter, they are grouped together and they get support. And we talk about levelling up, but I still don't see anything with the male victims of domestic violence. Thank you.
Joe, did you want to answer that?
I think Evelina wants to come in.
Oh, Evelina, yeah, I can see.
Yeah.
Sorry, you've got your hand up there. Sorry.
Yes, no, I thought that it was probably aimed at more of a housing service than Joe's area. So we don't have a shelter for male victims of domestic abuse, but we come across those cases every now and then, and we absolutely place them and are prepared to place everyone that is at risk of domestic abuse in a safe place with speed. That's not a problem at all. Our service is equipped to deal with that. And yes, in terms of the sort of the homelessness and people sleeping rough, we've got a really good team as well, which is also really well linked with other partners and other teams. And just over the last 2 nights, as you know, the colder weather meant that a sort of severe weather protocol was triggered. We have really worked tirelessly across the department yesterday in particular to take quite a number of people off the streets, put them up in all possible places. Places got filled very quickly, so we needed to be very creative as to where we put people, but I'm really pleased to report that absolutely everyone that we came across that was reported to us was put in a safe place. Furthermore, the community, just people on the street, we were really taken by their generosity. We have got a case where just a bystander called a taxi and paid for the taxi for the rough sleeper to be taken to the place where we found for them. We have had a number of community members just referring via StreetLink last night. So really, really good response from the community on the street. And as I say, everyone's been put in a place of safety. So and they will continue because obviously the weather continues for the next few days. So that support is at hand.
Councillor Ralph?
Yeah, I'd just like to come back to the male victim of domestic abuse. There's a different standard of care that is given to a lady who's been abused in domestic violence. They are sent to the Women's Refuge. This gentleman was offered a Premier Inn room with no support network, nothing. When we talk about levelling up, it really does need to be level. I've been chair of HOSC for 3 years. I've been going on about having the male shelter. We brought male domestic support units in to talk. Nothing has changed. If we're levelling up, it really needs to be levelling up. We need to be providing this service with support in Thurrock. A lot more men will come forward from what they're suffering if they know the support is out there. We are not doing it.
Joe, is there anyone that would like to comment there? Eloina, did you want to come back and then Joe?
Yes, no, I can. Councillor Ralph, I also chair the Women Violence Against Women and Girls Board, and we very often talk about provision for male victims of abuse, and I will absolutely take that for discussion. This is a very a sort of important topic for us. We always, however, go back to the statistics, and unfortunately in this matter there is a lot more evidence and statistics that talk about women and girls unfortunately being subject to violence. So that's why the vast majority of the provision is for women. But as I said, we will always, in housing, if we're aware, we will act on it. It's not necessarily, that provision is not just for our residents, or not just for council housing residents. We've got a safeguarding team. We very often get referrals from Marek, and we will take that victim or alleged victim to a place of safety. Obviously, we can't talk about individual cases on this forum. However, if we know that there is a danger, we really would work at very sort of short notice to take the person out of the location to the nearest available location that is safe. And very often it is a hotel that gets used for the first night. It doesn't mean that the person stays there for a long period, but if we need to remove somebody from their place of residence, very often on the day or on the hour, it's only another hotel that is available. I agree with you. There needs to be then the wider support network provided to them, and we do that through various contracts with our partners. We've got sort of changing pathways that can provide and will provide IDVA service, which is independent advisor advocate on domestic abuse matters. So it's definitely something that it's on our radar and we sort of look after for the council. But appreciate your comments and thank you so much.
Joe?
I think Evelyn has covered what I would have said. Thanks.
I know, Joe, I'll bring you back in, Councillor Ralph, because I can see you want to come back in. I know, Joe, we've had a conversation around male shelters and it closing down through lack of use because men prefer to have that support by a different mechanism. Now, I mean, I know that there's, when I went on the community safety program that they were outside the train station, there was a lady there from a charity that they deal with perpetrators, and they deal with female perpetrators as well within Thurrock, as well as male perpetrators. But I think if it's being raised, and it's been raised to me by a few councillors, is there like a piece of work? Because it's got to be evidence-based. I mean, we can't just build a shelter and hope people will come. It's kind of got to be a bit of both, hasn't it? But I don't know whether there's a report that Health and Housing could sort of do for us, or a briefing paper. Would that help, Councillor Ralph?
I think one of the issues, Chair, is that society is still of the view that if you're a man, you have to deal with it. Yeah, I think there's generally when I teach the anger management of mind. A lot of them there have suffered abuse, and if it's on the other foot, some will be arrested. So men still find it very, very difficult to come forward and talk about being beaten up at home. There's a lot of publicity on the other side, but with mean domestic violence, we have it where people's feet are cut with standing knives that are in bed because they come home late 5 minutes. There's things like that go on, and they're ashamed of coming forward. When we did have the male shelter, we sent them to East Ham, so they have to go quite far to get this support network. We don't provide nothing in Thurrock. If we advertise it is out there and get more people to open up about it, we don't know the extent of it. Now, when we had Shelter come down and speak about it, no, there wasn't far off. The stats weren't that different. We done Prevent the other week, and it was all about female being trafficking. When we looked at the stats, how many people died in that lorry down at West Thurrock? 19 of them were men. Now, those are the major majority. So we've got to change our thinking to be all-inclusive. Now, even the fact that it's men and girls violence as a topic isn't inclusive. We do make these fundamental mistakes. It needs to cover all aspects. Thurrock should be providing for everybody, not just based on their individual gender.
I think it's an issue. I was just going to ask if there was a member from the police here that would like to come in. Is that Terry? I can't really read it from here, but if you'd like to come in on that.
Thank you. Yeah, it's Inspector Terry Fisher. Thank you, Councillor. And look, to be fair, look, some really valid points raised there, but also some points that I think I'd like to challenge. And we'd like to talk about statistics, but we just start with domestic violence involving male victims, both with male and female perpetrators. There is definitely a stigma attached to it. And I think when we're looking at that, and there was a campaign run about 4 years ago trying to heighten awareness, similar to we do with hate crime campaigns, where the stigma attached from both a home, from being just a man in general, but also there's a cultural issue as well. Certain cultures where coming forward and reporting that you were being emotionally or physically abused by your female partner is a very difficult step for a man to take. So there's some work to be done maybe there if we're looking at that being an issue at the very start, and it's about promoting awareness and equality. I completely agree and support that. And I know as the police, when we're looking at domestic violence in any sex, there's, if you go back 20 years, all of that say, well, if it was the other way around, then no action would be taken. I can say categorically from the vast amount of training that I've been involved in, I've provided and also been part of, that we don't discriminate when it comes to sex and race, when it comes to domestic violence. If we turn up at an incident and we have a male party alleging an assault, and the criteria exists, which it will do in law under Section 24 of PACE and Code G, as we call it, an arrest will be made and an investigation will happen. It's as simple as that. The issue is therefore usually is that the male parties, and we do have it with females as well, won't want to prosecute. We have far less male parties fleeing domestic violence. And what I mean by that is where they feel they're vulnerable to further attack, or simply they refuse to leave or engage with police. And again, that's an issue in itself. The issue, I suppose, that I want to focus on is when we talk about VAW and violence against women and girls, when we start looking at the reason why that's coming to the fray, and we're not talking about, if we treat everything as the same, then we're not looking at individual issues and problems. We're not disputing that there are certainly male victims of some significant, very serious cases of domestic violence. Statistically speaking, though, if we talk about the offences identified which brought into the fray our VAW approaches, such as the murders of Julia James as an example, which happened obviously in 2020, we know statistically that women are feeling, or should we say, are reporting far more frequently that they feel vulnerable in public spaces. We also know that statistically speaking, from a domestic standpoint, and again, reporting could be an issue, but we know that statistically women are far more likely to be subject to domestic abuse, stalking, coercive controlling behaviour and or violence. And because of that, we can't necessarily treat everything as the same. We have to understand there is an issue, again, culturally, the way in which women are being treated, maybe by in society. And because of that, that's why we need to adjust it. It's not a one-cap-fits-all approach. It just simply doesn't work like that. VAWG is a very separate issue, which I think nationally we recognise as something needs to be addressed. And certainly the issue that's being raised by your councillor is an issue, and it is something that's important. But you can't treat them as the same thing. They're simply not. They're two very separate issues that we need to address and look at, and to ensure that both male parties are receiving support for domestic abuse, but we also get our VAWG approach right, because that is vitally important as well.
Joe?
Thanks. And just to build on what Terry was saying, I was just going to make the point that there is a difference between equity and equality, and we want the same outcomes for people. That doesn't necessarily mean that it's the same mechanism to get to those outcomes, and people aren't starting from the same place in terms of, I don't know, financial security, if we're thinking about housing options, for example. So just to add that to what Terry was saying, and the statistics are unfortunately quite stark in terms of the impact on males and females, and Terry's right. I think we do need a different approach to both, but we need an approach to both. And I wonder, because of those statistics and different rates of prevalence, coming back to what I was saying about partnership being really important in this domain, this may be something that actually it's not appropriate or even efficient for Thurrock to address alone. But if we start working with our partners to consider this, that might be a way forward. So there's obviously discussions around devolution going on within Essex at the moment. There's a work stream around community safety and community services as part of that devolution conversation. And I think this could be an area where actually working as a partnership across a broader geography might be more appropriate than working as a single unitary. So that is something that I can take into that discussion, if that would be helpful as a next step.
Thank you. I will bring you back in, Councillor Alf, but please bear in mind we've actually got 2 items and I'm going to drop one. So I'll just give you like 30 seconds. But before that, could I say that maybe Joe and Terry, you bring something back to Health and Wellbeing Board in the new year? Perhaps talk with Claire, see if we can get that onto the agenda. Would that be okay? So that we can sort of have a broader conversation on that subject? Yes, they're nodding their heads, so, okay. Councillor Ralph, 30 seconds.
It's actually a suggestion along those lines, Chair. I'd like you to to actually link up with a male domestic abuse charity to get their stats, their figures, and come back and see what they are saying. I really wish you'd take me up on that. I think it'd be really useful to have their say on this, Chair.
Okay, Councillor Ralph, yeah. Let's let Joe and Terry go away and have some discussions and come back to us if that's okay. I'm really sorry, Joe. We have literally got 10 minutes left. So could I ask you, I'm going to drop the next item, which, sorry, I've lost my page here on the title of it, the Violence and Vulnerability Board update. Could I ask you to update members electronically and then we come back to you with some questions? Would that be okay? Yeah, you're nodding, so we'll move then directly on to agenda item 9. Yes, is that, yeah. So let me just find it. The business case for the Mental Health Urgent Care Department. Supporting documents starts at page 71 of your papers. This is an external report, and on this occasion, Health Wellbeing Board covering report template wasn't used. We talked about that earlier. It would be very helpful for us if you could use templates going forward. That would be great. I'm sorry, I'm going to kind of like have to cut it a bit short. So whilst we've got 20 minutes for the item, 10 minutes to present, if you're able to condense it a little bit, that would be good. Leave us time for questions. Thank you. I'd like to invite Alfie Bandakapara Taylor to introduce it, and my apologies for not allowing you enough time at the end of this meeting.
That's perfect. Thank you, Chair. I'll give a quick summary and then Dr. Corrali, who is here with me, will give some context and background. So the purpose of this paper was just to bring to the appraisal and to update the board itself with regards to the development of the urgent care department, which has been in partnership and in collaboration with colleagues from Thurrock that have been involved in part of the planning and development as well. In context and in essence, the urgent care department is a model which has been developed with good practices in other areas, such as Camden and Islington. And it was a premise in terms of a model providing some rapid intervention for patients with mental health needs, which would entail and enable greater patient satisfaction, but also in terms of that impact on patient experience, on the basis that patients would be seen in a much more conducive environment and quicker, as opposed to being in acute urgent care department. If I pass over to Dr. Corrali, he will just give some quick context and in terms of the pathway and the model itself.
Thank you, Alfie. Thank you, everyone. My name is Milind Corrali. I'm a consultant psychiatrist and a medical director for EPUT. And we won't require 20 minutes. We'll finish in 12 minutes. And so this came about mainly for 2 reasons. One was there was acute pressures, significant pressures in the acute A&E. The patients were waiting for a long period. And when one of our patients get admitted to A&E, it often takes a couple of good few hours for that patient to be assessed, for the ambulance, if they are to be transferred, for those patients to be assessed in the Mental Health Act. And the message we were getting is during that period, we can get 6 or 7 ambulances through that cubicle. Also, our patient experiences the experience of our patient wasn't great going to acute A&E because of the probably not having the expertise and the understanding of such conditions among A&E staff. So I visited Camden and Islington Assessment Urgent Care Centre with a few of my colleagues and noted that this is an opportunity for us to create something similar in Essex, which meets the expectations of the patients, the requirements of the patients. So it's a 24-hour, 24/7 mental health urgent care unit, or similar to an accident emergency for patients with psychiatric presentations. It will receive patients from ambulances. Patients can drop in direct themselves. And the idea is to have a consultant-led team of senior clinicians who would do a thorough assessment and make appropriate decisions in terms of either the admission or signposting the patient. This team will also have expertise and understanding of the resources available in the community. So crisis houses work in collaboration with police services, ambulance services, housing services, so that there are no blockages in the patient pathway. And it'll also help us to manage our beds in a better way if we have a more senior and a dedicated team initially assessing the patient. From a patient's perspective, they won't have to wait, and they the concept of repeat attenders will be sort of done away with, because we would welcome patients if they want to come again and again, if they find coming to our A&E our assessment unit helpful. And that way we might be able to avoid admissions or pressures on the acute A&E. And the idea is to create a seamless pathway for patients who are in a mental health crisis. And we hope to reduce about 60 to 90% of acute hospital attendances once this mental urgent care centre is opened. We hope to open it, we plan to open it end of March. There have been certain delays because of getting the drawing plans of the architects and getting the unit ready. But we've started, the work started, we've started recruiting staff and working on the pathways, policies, procedures, and we're quite confident that this will make a significant difference to the experience of patients who are presenting in crisis, mental health crisis. Happy to take any questions.
Thank you. Do members have any questions? Councillor Ralph?
Yeah, thank you. I really welcome this. Anything that improves the experience of someone going to A&E with mental health problems. We have still got this problem where on the street, when someone is being, say they're wandering around and someone wants to report them to get their help, there still seems to be a breakdown on the 999 number of who they're going to send. So we still end up with maybe the police picking them up, and then the police are held up in Basildon Hospital for 7 hours trying to deal with the situation. I keep banging on about the street triage and how we're using those in Thurrock. Can any clarification use, have we still got the street triage in place? And are they active in Thurrock?
So I'll take that question, if I may. So yes, we still do have the street triage. I believe there was a member question with regards to the street triage, which we did respond to accordingly. It's being utilized. It's via 999. And I'm happy to get the street triage team to come present accordingly if there are queries and concerns about the street triage.
So I'm sort of pleased that this service is, that there's been separate funding for this service, and this service is not at the cost of cutting down any other services or resources. This is an additional service and that's being sort of set up.
Thank you, Joe. You've got your hand up.
Thanks. I also really welcome this. It sounds like a much more appropriate approach to supporting people in mental health crisis, and I think it will make a real difference to our residents and to our system. I just wanted to, I suppose, ask a question about the mental health pathway and that whole system approach, as I'm aware that we don't currently have a suicide prevention programme manager in place in the ICS, and that suicide prevention funding is going to end at the end of March. Whilst this sounds like a really helpful and excellent initiative, I'm slightly concerned that it could suck in money that might otherwise be spent on other areas of the pathway, and particularly we want to ensure prevention it remains a core part of our pathway to stop people getting into crisis in the first place. So I don't know how the ICS is squaring these two things, but is there an approach to continuing the suicide prevention work beyond March?
So happy to take that question. It's a valid and important point. Yes, the approach is suicide prevention is part of our commitment in terms of the funding, because we were wave 3, which came with SDF service development funding that comes to an end in March. As part of our mental health investment standard and our 23-24 planning, suicide prevention is of utmost priority. And while it will be business as usual, the program itself will continue and it will be funded.
Thank you. Any more questions? No. I'd like to thank you very much for your presentation. I actually, when I read this report, found it really exciting, and it's a much needed project, and it kind of goes in that line of like what we're trying to do as a local authority of making it human-led and wrapping our arms around the person rather than trying to fit a system. And it would be lovely to hear more about your progress as this continues on its journey. So maybe next year, give you time just to maybe come back and update us. But it's really exciting to see that mental health as well as physical health is being looked at together and will get its own A&E. I think it's about time mental health had an A&E department. I think it's great.
Thank you very much for your encouraging words.
Sorry?
I said thank you very much for your encouraging words.
No, thank you. It's recommended that members, we've commented, and note the contents of the business case for the Mental Health Urgent Care Department. Are members content to approve the recommendations? Thank you. Before I close, Stephen, I almost feel like I'm on a time delay with yourself, but will you be joining us at our next meeting, or is this going to be your last one?
Sadly not. This is my last meeting. I'm finishing at MSc on the 30th. So I'd just like to wish you all the best, really. I've really enjoyed working a lot in Thurrock and wish everyone the best for the future.
I'd personally like to thank you again, Stephen. You'll be sorely missed for me. You've been a real help across the ICS for me, and I know I've banged you a few emails here and there, and you've been really good at getting me some answers. I really do wish you all the best for the future and hope that we come across your path somewhere again. Councillor Ralph?
I didn't know that, Stephen. Thank you so much. You've been so useful to me and to Hosk as well. So I'd like to pass on my thanks to you as well.
Thank you. It's a pleasure. Thanks very much.
So that concludes today's meeting. Thank you to both members and presenters today. I'm closing the meeting today at 12:33. So Claire, don't shout at me too much, a bit late. I'd like to take this opportunity to wish everyone happy holidays and best wishes for the new year. And thank you for joining us today. Goodbye.
Thank you.